And I'll specifically talk to you about it through the lens of differences in career paths. I have no disclosures, but I do want to acknowledge that many of the studies that I'll be referring to today are not inclusive of the gender spectrum, but I will use terms such as family leave instead of paternity leave and non-childbearing parent instead of father when able to be as inclusive as possible of all kinds of family units. So I'd like to dedicate this talk today to Dr. Adams. As many of you know, my former program director. I was in his last graduating residency class. And as I'm talking to you all, I'm really reminded of his mentorship and his belief that I would be the doctor that I am today. So thank you, Dr. Adams, wherever you are. I couldn't have gotten to this point without you. Okay, so here's what we're going to talk about today. I'm going to give you a brief background about what we know about gender disparities in medicine. We're going to talk about my research in nonlinear career paths and how they might contribute to gender disparities. And then we're going to talk about what we've learned and what we can do to promote gender equity in the future. And I'll leave room for questions at the end of my talk, but if something comes to mind in the moment, feel free to enter it in the chat and we can address it at the end. So to start with the brief background, we know that women physicians take more of the burden of parenting and household duties. We know that this is true before COVID, and recent research has shown that this has worsened during COVID. Compared to male counterparts, women are more burnt out, have less scholarly publications, have lower incomes, and are much less represented in leadership roles. And when we talk about hospital medicine specifically, which is a specialty that's pretty new, created in the mid-90s at a time where 50% of medical graduates were women. The assumption was that leadership would reflect that. But 30 years later, only 19% of hospital medicine chairs are women. So why do we care? Why do we care about gender disparities? And I'd like to acknowledge, we know that men and women are different, and we have different strengths. But here are some examples of what women bring to medicine in terms of outcomes. So in terms of hospitalized patients, Sugawa et al. Analyzed those who are 65 years or older who were hospitalized from 2011 through 2014. And the authors found that elderly patients receiving inpatient care from female internists, so either hospitalists or general internal medicine physicians, had 30-day lower mortality and readmission rates compared with patients cared for by male internists. And this association was consistent across a variety of conditions and across patient severity of illness. Greenwood et al. Looked at mortality outcomes of patients coming to emergency rooms in Florida between 1991 and 2010 and found that female patients are more likely to survive an acute myocardial infarction by 5% when treated by a female physician compared to being treated by a male physician. Interestingly, the authors also found that male physicians are more effective at treating female acute MI patients when they work with more female colleagues. So we don't really know why women had better outcomes in these two cases, but the data does suggest that women may practice medicine differently and that we can all benefit from supporting women physicians to thrive in today's workforce. And it's especially important to focus on keeping women in medicine now more than ever. So some of you may have heard about the Great Resignation or a national increase of people quitting their jobs during COVID. But it's worth noting that women physicians were leaving the workforce even before the pandemic. In 2019, Frank et al. Found that within just 6 years of graduating residency, 40% of women were either part-time or no longer working. And now in the most recent Medscape survey of physician burnout in 2021, 1 in 5 physicians were thinking about quitting their current practice. And we don't have the data yet, but with the increased burden of household duties from schools intermittently quarantining, there's a good chance that women physicians will be disproportionately leaving the workforce fairly soon. So I'll admit, I never really thought about gender disparities when I graduated residency from Georgetown, but I really started to think about it when I became a mom. So I have 2 sons. Here's my oldest, Kai, with my first child, my golden doodle, Lola. And at the time Kai was born, I really thought that I had set myself up for career success. So even though I was only in my second year as a hospice, I was getting recognized by my boss for quality improvement projects. And I even ended up getting my first medical director role with protected time exactly 1 month before I gave birth. And I knew that my career was important to me, and I was determined to continue to have the same career success as a mom. But when I got back from maternity leave, I felt like my career had completely stalled. I felt like I was failing in my new medical role, and I felt like I was failing as a mom at the same time. It was like I was expected to be a physician as if I didn't have an infant at home, and to be a mom as if I didn't have a full-time demanding job, and it was exhausting. I remember going to lunch and venting about this to my colleagues who also happened to be moms, and they felt the same exact way. So some of them, out of necessity, had to decrease academic productivity in order to focus on family. And when they wanted to jump back into their careers, they felt like they were being left behind, like all of their opportunities had just dried up without them. And that got me thinking. So similarly to how women practice medicine differently, do women also take different career paths than men? And while the typical career path is linear, where you accumulate responsibility with time at a steady rate, similar to this purple line, it seemed like there was a subset of people who followed a more nonlinear career path, or a career that went through both periods of growth and stagnation, similar to this green line. So I wanted to know if women were more likely to take nonlinear career paths than men, and whether this career path specifically contributed to the gender gap we see within medicine. So I took a look at the literature. And in addition to finding that women physicians are more likely to work part-time than that of men, as I previously mentioned, I found that highly specialized women, so those with graduate degrees in business, law, and medicine, are more likely to leave the workforce or off-ramp compared to male counterparts. But I didn't find any data that focused on hospital medicine specifically. So a word about hospital medicine. When I talk to residents about becoming a hospice, I find that they look at it as a specialty that has a lot of flexibility because it's shift-based and it doesn't require extra charting or follow-up of patients when you go home because there's no clinic. It's often looked at as an ideal for work-life balance, but the reality is different. The reality is that you work a decent number of evening shifts and weekends, which takes away from time spent with family. And that brings us to my research. So after doing my own lit search and thinking about my own personal experience, I decided to look into studying nonlinear career paths formally on a systems level. So this is a cross-sectional descriptive survey study of hospice in 3 academic centers within the United States, looking at gender differences in the use of nonlinear career paths and their impacts. And it was published just recently this year, January 2020, in the Journal of General Internal Medicine. And to briefly go over the methods, it was a mixed method study that was survey-based, and it had closed and open-ended questions. It was multi-site at Northwestern, University of Colorado, and University of Washington, so 3 different time zones. And we primarily included physician hospice, so no APPs, no PAs or NPs were surveyed. And we focused on adult hospitalists. So those who are primarily pediatricians were also excluded, though med-peds hospitalists were included in this study. We didn't really time this, obviously, but our survey launched in July of 2020, right in the midst of the first wave of the pandemic. And to reiterate the purpose, we, number one, wanted to compare the frequency of nonlinear career paths by gender among academic hospitalists, but two, to also assess the perceived impact of two specific types of nonlinear career paths, those of extended leave and non-traditional work arrangements on hospitalists' personal lives and careers. So to define each path, we thought we define extended leave as taking leave from your current employment for at least 30 days. And we chose 30 days because we found that it was most inclusive of the majority of maternity leaves. And then in terms of non-traditional work arrangements, they were choices one may make that diverge from traditional schedules, responsibilities of the current hospice position. So in the literature, it's usually defined as flexible work arrangements, but considering a lot of people viewed hospice schedules as already flexible, we broadened it to use the term non-traditional work arrangements, which also reflected the different kinds of schedules a hospitalist might have based on their institution. So at Northwestern, we have a typical 7 days on, 7 days off schedule. So you basically work 2 weeks a month, get 2 weeks of the month off. But last I was at Georgetown, and you can correct me if this is wrong, the typical schedule tends to be Monday through Friday, day shifts, with 1 weekend a month, where you cover multiple different service lines. Some examples of non-traditional work arrangements that we gave in the survey was a change of career focus. So you could decide to focus on a more clinical path and not do any admin or academic work, or you could do the flip side. You could choose to do less clinical shifts and really focus on academic pursuits or admin time. You could change the type of shifts. So you, instead of working during the week, you could choose to do more weekends or less weekends. You can do more evening shifts instead of day shifts. You can go part-time, and you can also decline or defer leadership or further training. But we did leave it open to respondents to select other with an open text so they can kind of define it on their own too. And since the survey was sent out in the midst of COVID to a subset of people who were frontline in the pandemic, it was really remarkable that we got the response rate that we did of 51%. And we did find that the gender percentages reflected that of the sample population. And that was 55% women, 40% identified as man. And we did leave the option to identify as non-binary or other as well, though nobody actually self-identified as such. And 5% said that they preferred not to answer. I do want to note that the median age is 36 to 40 years old, which does reflect how new our specialty is. It was just created around 30 years ago. But it also reflects the national average of the median age of a hospitalist. So before I go to the results of the study, I want to do a little audience participation. So everybody pull out your phones for a few survey questions. Don't worry, there are no wrong answers. I just want to get a feel for the people here and kind of give you a chance to learn a little bit about each other. So for those of you who are willing, I'd like to know how many men, what percentage of this group are men, women, non-binary, or other? Okay, so 64% women and 38% men here today. Okay, all right. And then keep your phones out. Okay, so keep your phones out. I want to get a sample to see how many of you have experience with extended leave. All right. So a little bit, we have a group that has less experience with extended leave, but still a decent amount. Okay, interesting. So here's what we found. Unsurprisingly, women within our sample population took extended leave more often than men. And the top reason for both in taking leave was the same for both genders. So it was for the birth or adoption of a child. Keep in mind that the median age was between 36 and 40. So I imagine if we had an older group, we might have seen more people selecting taking leave to take care of an elderly parent, for example. And also, unsurprisingly, we found that women take significantly longer leaves than men do. We also did a multivariable logistic regression analysis to look at independent variables and how likely they were to be associated with extended leave. So we looked at, really, there's just a lot of numbers on this slide, but I really want to focus on the two most important things. So number one, we found that women are 7 times more likely to take leave than men, regardless, independent of having kids or being married. And I think a large part of that is because there were a good amount of men who identified as being parents, but didn't take any leave. And then also, not surprisingly, having kids was an independent predictor of taking leave as well. So not super surprising. But when it came to non-traditional work arrangements, we did have surprising results. And we found that men and women take non-traditional work arrangements at similar rates. And even when we grouped the strategies that people take into negative or positive career impacts, we found that there is no difference between genders. And in fact, the most frequent reported non-traditional work arrangement among men and women was a change of career focus to a less clinical position in favor of academic or administrative pursuits. And both women and men shared the same reasons for taking non-traditional work arrangements, and that was for birth or adoption of a child and for burnout. Okay, so bring out your phones again, and this time you can have a little bit of fun with it. So for those of you who have taken extended leave, how would you describe your experience transitioning back to work in 1 to 2 words? Are people having trouble? Oh, there we go. Tearful, not vacation, frazzled, draining, difficult. Yep, I can relate. The worst. Reinvigorating. Okay, so we have some positive there too. Preposterous. That sounds like a Sanskrit word. Hard, difficult. Okay. So, yeah, not vacations getting bigger. Feeling behind. Yes. I understand that. All right. I'll give it a little bit of time so anybody else who didn't get a chance can weigh in. All right. Well, I've noticed that even though, some people may have found it reinvigorating depending on, the purpose of taking it, but I see a lot of negative experiences when coming back from leave, which also reflects what I found in our results of this study. So we did a qualitative analysis to 2 open text questions, and they were, what impact, if any, has your choice to take extended leave? And then in a separate question, non-traditional work arrangements had on your career and or personal life. And when we coded responses, we found that they could fit into one of 4 domains. First one being career, second being work-life integration and well-being, and last, personal. And what we found were that both men and women reported positive impacts when it came to extended leave in the well-being domain. So one woman wrote, those periods of time were hard but restorative and helped me to empathize with the struggles of others, while one man noted that the leave helped with burnout. Similarly, both men and women reported positive impacts of bonding with their children in the personal domain, but only men noted a positive impact within the career domain, stating, I felt supported by my bosses and colleagues in taking a full break from work without any lingering responsibilities. I was able to gradually return to work until I was back to full-time at a reduced capacity. Not a single woman described a positive impact in their career from having taken extended leave. And when it came to experiencing the negative impacts of extended leave, women reported negative consequences in every domain. For work-life integration, negative impact given the pressure to continue administrative work while on leave. In the well-being domain, one woman said, it put a huge strain on my mental health. Ultimately, I hit rock bottom from postpartum depression. In the personal domain, one woman wrote, it's been devastating personally, undermining my financial security and identity. In the career domain, quote, I felt that the leaves have resulted in me advancing less than peers who have not taken leave. I don't think this is an intentional choice by leadership. It seems more that I missed opportunities or was unable to apply for positions based on the timing of leave. And I want to contrast all of those experiences to literally one man in my study reporting a negative impact from taking extended leave, and that was in the career domain. He wrote, the leave period slowed my academic productivity in spite of continuing to do research and admin work. So a stark contrast between the experiences of men and women. But I do have more positive news to share in regards to non-traditional work arrangements. So both men and women had positive impacts in all 4 domains. Some main themes included burnout prevention, increased flexibility, increased time spent with family, and allowing for more career opportunities. And while both men and women noted negative impacts from taking non-traditional work arrangements within their personal lives and work-life integration, mostly citing boundary violations from having to bring work home during off hours, only some women and not men noted decreased career opportunities. So what have we learned from this? What can we do to promote gender equity in the future? So from this study, we learned that women reported taking extended leave twice as often as men and for longer periods of time. But more surprisingly, men addressed burnout and the demands of parenting by utilizing non-traditional work arrangements at similar rates. But with that said, women experienced disproportionately negative impacts for both career paths. So I often get asked if the difference in experiences that our study captured are primarily caused by the unequal burden of parenting between men and women. And to demonstrate this, here's my second son, Avi, showing you what can happen when you look away for 5 seconds. So my answer to this is yes, absolutely. Parental responsibilities that women disproportionately take on are a huge part of the problem. One woman in our study actually said, the extended leave itself wasn't as harmful as the underlying reason behind it. Having kids necessarily handicaps you from promotional activities as you are no longer able to be physically at the hospital and at local regional meetings that would allow networking and therefore be thought of for projects. I'm also regarded by some colleagues as not all in or checked out because of the responsibilities outside of work. And there's growing evidence that family leave policies play a crucial role in perpetuating the unequal balance of parental responsibilities. So here in the US, we have FMLA, which some of you may or may not be familiar with. It stands for Family Medical Leave Act, and it's through the Department of Labor. So this provides 12 weeks of unpaid job protective leave per year. It applies to all public agencies and for companies with at least 50 employees. But the employees are only eligible if they've been working at that current job for at least a year. So FMLA is often used for several reasons: for birth of a newborn, for adoption or foster care, to care for immediate family members with serious health conditions, and to take medical leave when you yourself have a serious health condition. And I think it's funny because on the Department of Labor's website, they say the purpose of this act is to help employees to balance work and family responsibilities and to promote equal employment opportunity for men and women. But really, FMLA provides the bare minimum of not getting fired from having a child. And that's great on paper, but it definitely is not enough to promote equal employment opportunities for men and women. And here's why: not everyone has the means to take unpaid time off. So it de facto falls to the childbearing parent or mother who has to physically recover. And since there's no standard for paid leave policies, they vary widely throughout the country. In a cross-sectional survey of over 800 physician mothers, Junks et al. Found that half of physician mothers had no paid leave, and less than 50% of them said their spouse or partner was offered paid leave, paternity leave, paid or unpaid. And of those who did have the opportunity, few took it. And most often, the primary source for paid maternity leave was accrued sick time, followed by accrued paid time off that you couldn't use later in the year. And many physician mothers reported experiencing discrimination from taking leave, feeling pressure to return to work, for example, and receiving verbal admonishment for the increased workload of covering physicians. And for academic medical centers specifically, Riano et al. Reviewed family leave policies for the top 12 ranked US News and World Report medical schools in 2017 and found a wide array of leave policies, the mean length of which were 8 weeks for childbearing leave. And most family leave policies had several constraints. So some had policies were at the discretion of the department. Almost half of the schools said family leaves were only available to primary caregivers who care for a child more than 50% of the time. So de facto, the person doing the childbearing. Some had policies that included ambiguous language regarding the duration of leave. And the authors noted that the ambiguous policies can lead parents to not taking the full allotted time for fear of retribution. These authors suggest that forcing women to be the primary caregiver from the get-go perpetuates their role as primary caregiver throughout their careers, and that policy changes that focus on more equitable family leave is key to decreasing gender disparities in medicine and beyond. And that raises the question, what if men and women had equal paid family leave? What would happen then? And to answer that question, we're going to travel to Scandinavia and talk about policies in Denmark and Sweden. So both countries have similar welfare state ideologies. Both have high labor force participation of mothers, but they have very different family leave policies. And I do want to note, Hilkinen and al. For this study, they did refer to paternity leave instead of family leave and to fathers instead of non-childbearing parents. So I will be referring to them as such as well. So in comparing the two countries, Sweden has a culture that emphasizes shared parental responsibility, and in fact was the first country ever to pass a law dedicated to offering fathers paternity leave. Whereas Denmark, it is not a culture that focuses on shared parenting and really looks as the mother to do most of that work. And so the authors collected data between 1993 and 2001. And at that time, Sweden offered a 60-week leave that was split up between parents up to 8 years of a child's life. Compared to Denmark, who offered the childbearing parent 13 weeks postpartum with an additional 32 weeks that can be split between parents. So I'd like to note that both of these are much longer than what we offer in the US. And in terms of compensation, in Sweden, they had more equal compensation between men and women and compared to Denmark, where at the time of the study, men more typically worked in the private sector, which had less flexibility but higher wages, compared to women who worked in the public sector, which had more flexibility and lower wages. And therefore, men would actually lose more money by taking time off, considering that the private sector only offered 60% compensation while the public sector provided 100%. And as you can see, in Sweden, a culture that encourages men to take leave and participate in childbearing, the majority of men took paternity leave, that's 77%. Whereas in Denmark, only 50% of men took leave, and for a much shorter amount of time. So in Sweden, the mean paternity leave was 4.5 weeks, but the authors only had access to the first 15 months postpartum. And remember that in Sweden, you can take that leave up to 8 years after a child is born. So what they didn't capture was that men often took time off at the time when their partner was re-entering the workforce. This is in stark contrast to Denmark, where if they took leave, it was only 1 week, and not a single person took more than 2 weeks of leave who was a father. But when it came to maternity leave, Sweden had 40 weeks, and Denmark on average had 28 weeks. So this study illustrates that it isn't enough just to offer men leave. You have to have a culture that explicitly incentivizes them to take it. And looking in the Swedish cohort, where some men did take long paternity leaves, the authors found that when a father increases their length of leave, women tend to return to the labor market sooner. And in the author's regression model, controlling for compensation and number of children, the authors predicted that if a father took 4 months of paternity leave, it would decrease the mother's leave by 4 weeks. So essentially, if father shared more of the childbearing burden from the get-go, women would be allowed to enter back into the workforce earlier. And this is why equal leave works. When men spend more time taking on parental responsibility, women are allowed to focus on their careers sooner than they otherwise would have. The author also suggests that if we try to promote equality between men and women in the workforce, more leave should be directed explicitly to fathers without decreasing the entitlement period of mothers. And the reason why can be illustrated by what Great Britain did in 2015. So they allowed for family leave that would be split by both parents within the first year. But since the non-childbearing parent taking leave would result in a lower maternity leave during this critical time, few men actually took leave at all. So as I've mentioned, women in academic medical centers don't have the luxury of 40 or even 28 weeks of paid leave. But one can imagine that if men, in addition to women, were not only getting paid leave, but explicitly are incentivized to take it, this emphasis from the get-go, from birth, that men and women should share child rearing responsibilities can ease the gender disparities that we see in the medical world and beyond. And unfortunately, the unequal responsibilities of parenting doesn't completely explain the gender disparities within career trajectories. And I know that the main focus of this talk is about career trajectories, but I would be remiss if I didn't mention a little bit about gender discrimination and bias. So I'll use an example. One woman colleague told me a story about passing out a process map to her colleagues to describe a new role that she was helping to create. And an older male colleague says to her, "Well, look at you being a little helper." And while he didn't have any ill intent, she described how he made her feel so small and insignificant in that moment, despite the fact that she was about to speak to her division about a role that she was leading the creation of. And you may argue that he could have said this to any younger colleague, but the data supports that women experience gender discrimination from both colleagues and patients more often than do men. In a survey-based study of 18 academic hospitalist groups in the US, in 2021, so present day, Banderi et al. Found that about 70% of women reported experiencing being mistaken for a non-physician, like a nurse, for example, during their careers, compared to 20% of men, by both other physicians and non-physicians. They also found that women reported sexual harassment from both patients and colleagues more often. And ultimately, they found that compared to male peers, women felt less respected by patients, less respected by other physicians, and ultimately perceived that their gender likely negatively impacted their career advancement. So over time, and certainly over a course of a career, even minor discriminations, like the example of being called a little helper, can feel like death by 1,000 cuts. Fighting that uphill battle with the added pressure to overcome discrimination, especially for women physicians of color, can ultimately lead to women avoiding pursuing leadership positions at best, and at worst, leading them to leave the profession altogether. With that said, times are changing, and there's evidence that men of this generation want gender equity too. They want to spend more time with their kids. So in this study in 2008, they found that men do spend significantly more time with household tasks and parenting compared to 30 years ago. And while it is definitely not equal, there's an improvement. And in my study, men were choosing non-traditional work arrangements at the same rate as women to address conflicts with parenting. And while there are several studies on how COVID has set back women more than men when it comes to research and academic productivity, this 2021 Medscape study of physician well-being and burnout saw that male physicians cited work-life balance as their biggest concern within the workplace, similar to that of women. But as I've mentioned, academic institutions with regards to extended leaves, at least, do not reliably promote policies that support men taking equal household and parenting responsibility. So here's what we've learned so far. We've learned that academic medical centers can do a better job of having clear policies for family leave. We learned that when men take longer family leaves, women return to the workforce earlier. But offering paid family leave isn't enough to guarantee that men will take it. We need a culture that supports them to take it. And times are changing. Men want flexibility and work-life balance too. So we've seen some examples of other countries, but you may wonder, is this possible in the US? And the answer is yes. So in 2016, Etsy announced that it would offer employees around the world who have biological or adopted children 26 paid weeks of parental leave, regardless of the parent's gender and who is the primary caregiver. Facebook offers 16-week paid parental leave and reimburses new parents for necessities like supplies and childcare. American Express has a full 20 weeks of paid parental leave. And even the government, the federal government, has caught on to equal paid leave. Starting 2 years ago, all federal employees have up to 12 weeks of paid parental leave, regardless of the parent's gender and who is the primary caregiver. And you might say, well, obviously, huge corporations outside of medicine are able to manage this. They don't have to provide high quality of care for patients 24/7. But while uncommon, I'm here to tell you that it is possible in the medical profession. And I'll give you an example of a program in medicine that has made it work. So the University of Colorado allows family leave for up to 6 months with 12 weeks of paid maternity leave, in addition to both parents being able to use accrued sick leave, vacation time, and unpaid time. And they ended up adopting a policy for 4 weeks of paid non-childbearing leave in 2018. And as you can see, even before the 4 weeks were offered, the hospice division in Colorado already had a culture that supported men taking leave. In fact, the average man taking leave took 9 weeks for child rearing. But once they instituted the 4 weeks paid, it went from 9 to 14 weeks, similar to that of women who on average at this site took 15 weeks of maternity leave. So it is possible, even in the medical field. So at this point, we found that women do take nonlinear career paths, specifically when it comes to taking extended leaves more often than men, and disproportionately experience the negative effects of it. But maybe nonlinear careers are the future for both men and women in order to promote gender equity within medicine. And in order to promote gender equity in our field, we need gender neutral paid family leaves and flexible work policies where it's the norm for both men and women to use them. And by no means do I suggest that it's easy. I know it's hard to find coverage when people are out, and I know it's hard to maintain profitability. But it is possible, and it's necessary to maintain physician well-being and retain women in the workforce. And what I really want you to remember from this talk today is that gender equity is not a woman's issue. This is a man's issue too.